A very good evening to you, ladies and gentlemen. I'm honored to welcome you to the 61st webinar of the BASL Association of Sri Lanka and the 25th webinar of the 4th webinar series. And to make this occasion more special, today's webinar is in collaboration with the Ceylon College of Physicians, and I warmly welcome and thank the President of Ceylon College of Physicians for proposing to conduct this webinar today. These webinars are organized by the Seminars Committee of the BASL, chaired by Secretary of BASL, Mr. Rajiv Amarasuriya, and the conveners, Assistant Secretary, Mr. Pasindu Silva, and the co-conveners, Mr. Pandula Vanniyarachi, Mr. Oshan Uberatna, Ms. Ann Devanand, and Ms. Nikini Mapitigama. I would also take this opportunity to thank the President of the BASL, Mr. Salih Peris, President's Council, and the other members of the Management Committee of the BASL for all the support and guidance. Throughout these past few months, we have seen some of the most brilliant legal minds in the country share with you their knowledge, and today we have medical experts to share with you their knowledge on managing heart disease. I'm sorry, ladies and gentlemen. Today we have medical experts to share with you their knowledge on managing heart disease, diabetics, and asthma. In celebration of this collaboration, I would like to first invite Mr. Salih Peris, President's Council, President of the BASL, to speak a few words. Sir, over to you.
Good evening. So let me first of all thank the Ceylon College of Physicians for collaborating with the Bar Association of Sri Lanka in presenting this webinar. This was initiated by the President of the college, Professor Arosha Disanayaka, who reached out to the Bar Association as part of his initiative to engage with other associations. And so when we discussed, we thought it would be a good idea that the members of the legal profession would benefit from the insights into asthma, heart disease, and diabetes from the senior members of the Ceylon College of Physicians. So let me thank Professor Arosha Disanayaka, and also Dr. Newmali Amarasena, Dr. Manil Kasumanitilaka, Dr. Chandimani Udugodage, and of course, Dr. Lushantha Kannangra, who is a moderator. I hope that this will be the beginning of collaboration between our associations. I think there are many areas where we can collaborate, and I do wish that we will do so in the future. Let me also thank the Seminars Committee headed by our Secretary, Mr. Rajiv Amarasuriya, for initiating this and for organizing this webinar. Thank you.
Thank you, sir. Next, I would like to invite Professor Arosha Disanayaka, President of the Ceylon College of Physicians, to speak a few words. Professor, over to you.
Thank you very much. It is indeed a great pleasure and a privilege to be joining the bars with the Bar Association of Sri Lanka. I am the President of the Ceylon College of Physicians. I'll just spend 2 minutes with you. The first minute explaining what the Ceylon College of Physicians is. Our organization this is our 55th year. Now, we are all the specialist physicians gathered together. Now, specialist physicians in terms of those who are doing internal medicine or the general medicine specialists, as well as cardiology, neurology, respiratory medicine, kidney specialists, everybody. Other than those who cut and chop, the surgeons and the obstetricians, well, everybody else is gathered around the Ceylon College of Physicians. So we are, I think it's fairly accurate to say that we are the thought leaders of the medical community along with the College of Surgeons and College of Obstetricians and Gynecologists. And Ours is perhaps the largest and the oldest professional medical organization when it comes to a specialist group. There's only one association, that's the Sri Lanka Medical Association, which is older than us, but we are modeled on the Royal College of Physicians, London. So that's why among our resource persons, we will see a cardiologist, an endocrinologist, a pulmonologist, and also Lushanti, who is moderating. She's a specialist in internal medicine. So that's the kind of group that we are, and that's how we operate. We work together to improve health in this country. In terms of what we're trying to achieve here, in terms of objectives, now over the pandemic period, one thing which became very clear to all of us was that we couldn't survive alone. We were interdependent on each other for mere survival. And that conferred upon us the resilience that was required to overcome the difficulties that we were facing. During 2022, during the year that I'm president and my colleagues are on the council, we've thought about not just reaching out to fellow doctors, but reaching out to non-medical professional organizations so that we get together with each other and we do good for the society. So I contacted Mr. Salia Piris, the president, and he was very gracious to be present at my induction as the president. And then, of course, we have been having discussions. So today is the start. I mean, I know that we've met in the past to play cricket and dance and party, but today we're going to do something a little more than that. We're going to go towards health and talk about some important issues with the membership. But then the objectives, the future that Salia and I perceive together is actually a lot more than that, where we are going to collaborate and engage with each other in promoting social well-being, social justice, maybe strengthening civil society, all of that as two of the most powerful professions in Sri Lanka that we could do. We could get together and do a lot for civil society. So that's our ultimate objective. And this, I believe, is a good start to that process. What we must remember is there are lawyers in every corner of the country. There are physicians also in every corner of the country. May I invite you all at local level to get to know each other and start working together so that we adopt a not a top-down approach, but a bottom-up approach towards working with each other. So I teach medicine in Galle, I work as a specialist in Galle, and I will work with my colleagues in Galle, as well as, of course, the center because I'm the president. But may I invite all of you to collaborate locally so that we will build a very strong network between law and medicine in Sri Lanka. So that's all I have to say. I look forward to listening to the talks myself because there are three other top physicians in the country who are going to speak to you. It's over to you. Thank you very much.
Thank you, Professor. Before we proceed, ladies and gentlemen, I wish to warmly welcome our distinguished panel for this evening, comprising the following experts. And first and foremost, I welcome Dr. Nawamali Amarasena. Dr. Nawamali Amarasena obtained a Bachelor of Medicine and Bachelor of Surgery in January 1985 from the Faculty of Medicine, University of Colombo, with second-class honors and a distinction in medicine. She was awarded the Rajasuriya Prize for Clinical Medicine. And also she obtained her MD from the Postgraduate Institute of Medicine, University of Colombo in December 1989, where she was placed in the order of merit and awarded the John Stokes Gold Medal for the best performance in the MD Part 2 examination. Having selected cardiology as a specialty, she did initial training at the Institute of Cardiology, National Hospital of Sri Lanka. In 1991, she was awarded a Commonwealth Scholarship to the United Kingdom to undergo further training in cardiology. And she has spent 3 years at the John Radcliffe Hospital, Oxford. And she was successful in obtaining MRCP in 1992 and was appointed clinical lecturer in cardiology during her final year in Oxford, where she participated in many research projects, including clinical trials. On her return to Sri Lanka in 1995, she was appointed as a consultant cardiologist of the Sri Javadhanpur General Hospital as the first cardiologist. As there were no cardiac unit at that time, she was able to establish the fully equipped cardiology unit and currently the senior cardiologist at Sri Jayawardhanapura Hospital. Next, I would like to welcome Dr. Manil Kasumanitilaka. Dr. Kasumanitilaka is currently a consultant endocrinologist at the National Hospital of Sri Lanka. And Dr. Manil is currently the Vice President of Diabetes Association of Sri Lanka. And he was former chairman of Sri Lanka Diabetes Federation, also past Vice President of Sri Lanka Medical Association, and also past President of Sri Lanka College of Endocrinologists, and former Secretary of South Asian Federation of Endocrine Societies. And Dr. Manil was trained in endocrinology at the National Hospital of Sri Lanka and at St. Bartholomew's Hospital, London, United Kingdom. He has also published many publications in peer-reviewed journals and actively involved in formulation of national and regional guidelines in the field of diabetes and endocrinology. Dr. Manilka is a principal investigator in 2 international multi-center randomized clinical trials on new diabetics drugs. He was then invited to write a chapter on endocrine emergencies in pregnancy for the textbook of obstetric and interpartum emergencies edited by Sir Sabaratnam Arul Kumaran and Edwin Chandra Haran, published by the Cambridge University Press, United Kingdom. I also welcome Dr. Chandimani Udugodage for this webinar, and she's a consultant respiratory physician and senior lecturer at the University of Sri Jayawardhanapura. And she obtained her MBBS in 2003 and MD in 2009, MRCP in 2007, and FRCP in 2017. Dr. Chandimani is also board certified as a respiratory physician in 2012. She is currently the president-elect of the Sri Lanka College of Pulmonologists and the chairperson of Sleep Assembly of the Sri Lanka College of Pulmonologists, and also an international advisor for the Royal College of Physicians, London. And our moderator this evening is Dr. Lushanthi Kannangar. She obtained her MBBS and MD from the University of Colombo and MRCP from United Kingdom. And she also holds a diploma in writership and communication from University of Sri Jayawardhanapura. And currently she is a consultant physician at the teaching hospital of Karapiti. Without further ado, I would like to invite Dr. Lushanthi to take over. Dr. Lushanthi, over to you.
Thank you very much for your kind introduction. As Professor Arosha Disanayake mentioned, this is the first webinar organized.
Dr. Lushanthi, you have gone on mute.
Can you hear? Did you all hear what I talked earlier? Thank you.
No, Dr. Lushanthi, you were on mute.
Thank you for kind introduction.
Right, you are.
Professor Arosha Disanayake mentioned, this is the first webinar organized by the Ceylon College of Physicians in collaboration with other professional organizations. As we have talked a lot about this webinar and the lectures, and we have already introduced our speakers. Without taking much time, I would like to invite our first speaker for today, Dr. Neomali Amarasena, Senior Consultant Cardiologist, past President, Ceylon College of Physicians. She is currently working at Sri Jayawardhanapura General Hospital as Senior Consultant Cardiologist. I would like to invite Dr. Neomali Amarasena to deliver the first lecture on heart disease. Over to you, Madam.
Thank you all for your kind words of introduction. Cardiology is a rather extensive field, and you can deal with several aspects. For instance, there's congenital heart disease, there's valvular heart disease, but what is of more interest to professionals like yourself is the matter of heart muscle disease, which in other words, heart attacks. So I decided to talk about how to prevent a heart attack. Now, what is heart disease? The heart is one of the most hard-working muscles ever. Yes, one of the most hardworking muscles of our body, which pumps 4 to 5 liters of blood every minute during rest. And it supplies nutrients, oxygen-rich blood to all body parts, including itself. Now, the coronary arteries are what feeds the heart. It keeps it nourished with blood. And as you can see, there is the left and right coronary arteries. I'm sorry. And over time, fatty deposits called plaque builds up within the artery walls. And this narrows the artery. And this process is called atherosclerosis. When this occurs in the coronary arteries, the heart does not get sufficient blood. And then the condition is called coronary artery disease or coronary heart disease. And if you look at this slide, most people are under the impression that fat deposits at an old age. Actually, nothing can be further than the truth. It starts when you're about 2 years of age, where cells which are full of fat, first of all, start lining the arteries, and those are called foam cells. And then you will get a fatty streak, which becomes an intermediate lesion. Then the atheroma builds up, that is atherosclerosis. Finally, there is fibrosis on the surface. And then it becomes a very complicated lesion where for some reason, if the fibrous cap which covers this lesion ruptures, you get a clot forming. And if the clot is big and obstructs the artery, that will stop the blood flow going to the distal part of the artery and cause damage to the heart muscle, which is a heart attack. Now, are there other organs which are affected? Yes, the brain, where you can get a stroke. Again, it's the same process. And if by any chance any of you find that when you're walking, there's any pain in your calf muscles, then that is due to peripheral vascular disease. Again, the same process affecting the arteries of the leg. So what are the symptoms of coronary artery disease? Most of the time, there are no symptoms at all. And that is what is most dangerous about it. If you get a chest discomfort on exertion, which is relieved by rest, that is known as angina pectoris. And a myocardial infarction is where you end up, you get a severe chest pain. You may or may not get a severe chest pain, and that causes death of the heart muscle, and which eventually leads to heart failure or even an irregular heartbeat. And the worst comes to worst, there can be sudden cardiac death. Now, what are the symptoms of a heart attack? Actually, there are many people who have silent heart attack, but let's talk about the ones where it's not silent. What you get is a constriction and it's a kind of discomfort. It is not the type of pain you get with a colic. It is sometimes it can be quite subtle, but sometimes quite severe. It can be a crushing pain, which is on the chest, which can go along the arms, to the throat, to the jaw, to even the ears, or it can go back to the back of your chest, or it can present something like a gastric pain. And you might feel that you're very sweaty at that time, very anxious, you can be pale, and your heartbeat can become quite irregular and might even want to go to the toilet at that time. And there's one classical symptom which people with heart attacks have, and that in Latin is known as ango animi, or fear of impending death. If you or somebody you know is having any of these symptoms, go to the closest emergency unit after giving the victim an aspirin to chew. Now, it is a huge problem worldwide, where there are 12 million deaths annually. However, over the last 30 years, in the more developed countries with very good healthcare systems, there have been large declines. Unfortunately, that doesn't apply to South Asia. There have been an alarming increase in the developing countries. And they are more susceptible than any other ethnic group. You can see 6 times more than the Chinese, 20 times more than the Japanese, and it occurs at a lower cholesterol level. And they also get the disease at a much younger age and follows a more severe and a malignant course. 3 times higher rate of second heart attack and 2 times higher mortality than Caucasian whites. So why? Well, there's a genetic predisposition, and the South Asians have a notoriously poor handling of their fats. They also get diabetes at a much younger age. And There are also environmental insults like urbanization and sudden change in lifestyle, which can also affect them. So what increases the risk? Well, there are some things which you can help and some things you can't help. You can't help your sex, you can't help your race, you can't help your family history. And however much you may like it, you can't help your age either. But you can control your cholesterol, you can stop smoking, control the blood pressure, diabetes, reduce your obesity, and control alcohol, and as well as be a little physically active. So, but also, you can't just say it's all in the family. Some people with family history also have other risk factors like high cholesterol and high blood pressure, and also certain food and exercise habits and exposure to smoking runs in families. So you can change your lifestyle and modify the risk factors even if you have a bad family history. So you eat right, exercise, don't smoke, control blood pressure and diabetes, and decrease your stress levels. Now, what is cholesterol? It's a type of fat. However, everyone needs cholesterol. It serves a vital function in the body and it circulates in the blood. But too much cholesterol can deposit in the arteries in the form of plaque and block them. And there are no symptoms till you get your heart attack. Now, there are two sources. One is food and the rest is made in your body. Generally, the food sources are food containing animal fat and meat products. Now, there's what you know as good and bad cholesterol. The LDL cholesterol is known as bad cholesterol. It has a tendency to increase the risk of heart disease, and it's a major component of the plaque that clogs the arteries. The HDL cholesterol, which is known as the good cholesterol, it's high in women and increases with exercise. And it helps carry some of the bad cholesterol out of the arteries. Now, those who are overweight, and particularly those who are obese, have 2 to 6 times the risk of developing heart disease. There's something called the normal waist-hip ratio. Now, that can go a bit haywire and give you some funny shapes. You can be either a pear or an apple. Now, the pear-shaped paunch stores fat on the hips and thighs just below the surface of the skin, while the apple-shaped paunch stores body fat around the abdomen and chest and surrounds the internal organs. So those who are apple-shaped are at a higher risk. Physical inactivity, again, is one of the causes which can predispose towards getting heart disease. Cigarette smoking, as you all know, is one of the major risk factors. It increases blood pressure, it decreases the good cholesterol HDL, it damages the arteries, the lining of the arteries and the blood cells, it increases heart attacks, and the cigarette smoke contains more than 4,000 chemicals, and 200 of these chemicals are poisonous. And by smoking, you not only hurt yourself, you hurt all your loved ones as well as your colleagues if you are smoking, because they become passive smokers and can have the same diseases that you have. Now, alcohol consumption is a somewhat controversial topic. In small amounts, it was believed to be beneficial, like 1 to 2 drinks. In large amount, it adds fat and calories and raises blood pressure, which is again a risk factor. 4 drinks a day, and you end up with the gastroenterologist instead of the cardiologist, and you might end up with cirrhosis. This is a very fine line, and it's finer for women as they are at higher risk. Now, for those who enjoy their drink in the evening, there's a little bad news, and that is that the World Heart Federation, in their policy brief in January 2022, based on a 25-year study, which was published in The Lancet, said that alcohol consumption of any amount, even as little as 1 glass of wine a day, leads to a greater risk of developing cardiovascular disease, such as heart failure and stroke. So now it is up to you to decide, when you are offered a glass of wine, whether it is better to drink that or an even worse drink, like a sugary fruit drink, which is the usual welcome drink which we are greeted with whenever we attend a function. Diabetes is an important risk factor, and 80% of diabetics die from heart disease. I won't speak much about it, as Manil will be talking to you afterwards. Now, what about these risk factors? They operate across a continuum, and the risk is multiplicative, where many risk factors coexist, and risk factors often cluster together. And it's interesting that the majority of events arise in individuals with moderate elevations of many risk factors than from marked elevation of a single risk factor. So you might have a very high cholesterol, but if you don't have a family history, you're not hypertensive or diabetic, or you don't smoke, it's quite possible that your arteries might be quite normal. Now, there are different ways of assessing risk. The non-communicable disease division in the Ministry of Health has put out charts for men and women of this country so that they can figure out what their risk level is. I just put this atherosclerotic cardiovascular disease plus app because it's an easy app to download. It is of course not validated for our population, but it's reasonably okay. And at least you can find out whether you're low risk, intermediate risk, or high risk and know what to do next. So now what we do every day is we protect ourselves, we protect our loved ones. So we protect ourselves when we're crossing the road, when we are trying to buy something, we go and ask people for help, we go and do market surveys, we do all sorts of things. But what do you do to help protect yourself from this number one cause of death, which is heart disease? For my car, I want the best mechanic. But for my own body, I follow hearsay and advice from friends, local quacks, and just anyone and decide for the worst. These are things which most people say. We have never had a test or a retest, never been to a doctor. I hate them. Well, maybe, but you do need them sometimes, just as the doctors will need the lawyers also when somebody encroaches on their land. You never take medicines. My blood pressure is normal, so I stop the medicines. Then there are miracle men and miracle medicines. So many of them. I mean, we saw so many of them popping up during the COVID, particularly at the start of the COVID pandemic. And I'm my own doctor. No fees too. So let's get on to some of the things which are important, like fats and oils. Fats actually are essential for good nutrition and health because they provide essential fatty acids which the body cannot manufacture and act as insulators to maintain body temperature and improve palatability of food and promote digestion and provide the greatest energy output per gram of any food source. They also carry fat-soluble vitamins like A, D, E, and K. This slide shows you the different types of oils and what kind of fats are included in them. And so you can see that when it comes to saturated fats, coconut oil heads the list, while when it's monounsaturated fats, olive oil and canola and peanut oil are there. And the oils rich in polyunsaturates are like soya bean, sunflower oil, corn oil, flaxseed oil, and so on. So saturated fats are basic. What it means is that the fat is saturated with hydrogen and they are solid at room temperature. For example, lard. They increase the levels of LDL, the bad cholesterol, decrease HDL, and increase the total cholesterol. When you take fat, you must limit your intake to about 7 to 10% of the total calories required. Polyunsaturated fats are unsaturated fats which are liquid at room temperature and in refrigerator. And they help the body to get rid of newly formed cholesterol. While monounsaturated fats are liquid at room temperature but start to solidify in the refrigerator, like canola, olive, peanut oils, and avocados. And they decrease total cholesterol and lower LDL levels. Trans fatty acids are unsaturated fats, which have hydrogen added to them to give them a longer shelf life. But they tend to raise total and LDL cholesterol and lower the HDL. And you find them in fast food restaurants and in commercial baked goods like donuts, potato chips, and cupcakes. Omega-3 is a type of polyunsaturated fat which consistently lowers the serum triglycerides and may also have an effect on lowering blood pressure. It's found in oily fish such as salmon, tuna, and herring and is available as a supplement. Now, when you want to prevent heart disease, first of all, look before you eat. You try and have a nice mix of fruits and vegetables every day and eat a variety of grain products. Choose non-fat and low-fat products. Use less fat meats, chicken, fish, and lean cuts, and switch to fat-free milk or toned and skim milk. And you limit your intake of food high in calories and low in nutrition like soft drinks, candy, and junk food. And limit food high in saturated fats, trans fats, and cholesterol. Eat less than 6 grams of salt a day and have no more than 1 to 2 alcoholic drinks a day if you're a regular drinker. There are certain foods which are rich in cholesterol and saturated fats. You don't have to avoid them altogether, but limit it. For instance, taking about 3 full eggs a week is fine. And but you have to also remember that there are hidden fats, like in bakery biscuits, patties, cakes, and pastries. And if you look at this list, you can see that they all taste pretty good. So in fact, the mantra should be, if it tastes good, spit it out. Exercise is essential, and it helps you to maintain a level of physical activity which keeps you fit and matches the calories you eat. And it reduces the incidence of obesity, increases HDL, lowers LDL and total cholesterol, and helps to control the diabetes and hypertension. And mortality is halved in retired men who walk more than 2 miles every day. Someone who is inactive has as great a risk of having heart disease as someone who smokes, has high blood pressure, or has high cholesterol. And with regular exercise, blood pressure in those with hypertension is reduced by as much as 20 millimeters mercury. So moderate to intense physical activity for 30 to 45 minutes on most days of the week is recommended. Complicated exercise machines and sweating it out in gyms is not essential. Just walk. The rule 3 is to stop smoking now or preferably yesterday. The risk of a heart attack starts decreasing within 24 hours of quitting smoking. Within 1 year of quitting, coronary artery disease risk decreases significantly, and within 2 years, it reaches the level of a non-smoker. And smell and taste improves within days, and within 3 months of quitting, the smoker's cough disappears in most people. You can be prescribed an Nicorette patch if you're absolutely addicted. But as the cartoon says, it's better to keep a patch over your mouth. Now, all these risk factors have multiple beneficial effects, or they have deleterious effects if you continue them. For instance, tobacco not only affects the heart, but it can cause cancers, can cause chronic respiratory disease, and it affects oral health. The same goes for most of these other risk factors. Now, there's one number you need to know, and that is those desirable numbers are what your cholesterol is. You see, it's good to just do a lipid profile once in a way, and you can see that if your cholesterol is less than 200, LDL less than 100, and HDL is more than 40, more than 45 for men and more than 55 for females, and triglycerides less than 200, that is desirable for somebody who doesn't have very many risk factors. So get these tested routinely and keep it under control. The only thing worse than finding that you have one of these conditions is not finding that you have it. And the benefits of reducing the cholesterol is that a 10% reduction of blood cholesterol produces a 20 to 30% decline in coronary artery disease deaths. And all adults over 20 years should get themselves tested. If normal, check in about 5 years. If elevated, really target lifestyle modification. If you don't succeed in that, you may need some drugs. Blood pressure or the optimal levels are 120/80. Anything less than, if you target anything less than 140/80, it will be quite adequate. And you should again get your blood pressure checked at least once every 2 years. And there are no symptoms to tell you that you have high blood pressure. People think that they should get a headache, but that is, you're lucky if you get it. Most of the time, even with a 200/100 blood pressure, you may not have a headache till you get your first stroke. Again, you have to modify your lifestyle, and with particular emphasis on salt restrictions. And do not stop your medicines without consulting your doctor, even if the blood pressure becomes normal. All adults should have their blood sugar checked regularly, as there are no early symptoms of diabetes. This, as I said earlier, will be dealt with later. Now, if you or someone in your family is already diagnosed with heart disease, don't get disheartened. Science has made significant progress. You just eat healthy, walk regularly, quit smoking, and keep your weight under control. And in addition to improving your heart health, these measures are sure to enhance your appearance. So you adhere to your medicine and listen to your doctor. Now you have certain ways where you can screen patients to see whether you have got heart disease. And an ECG a stress test. And if these are not good, you might have to proceed to a coronary angiogram. So there are all kinds of other tests also, like blood tests, where you can actually check out your kidneys, your thyroid functions, because if you're hypothyroid, you're likely to have high cholesterol, and all that leads to coronary artery disease. Also, the presence of anemia is important. Then chest X-ray, echocardiogram, and there are also more advanced tests like stress echocardiogram, CT scans, and nuclear cardiac scans. What the exercise test does is it checks for changes in your heart while you exercise, and the resting ECG is always done before the exercise. And not always accurate in the fact that you can get false positives and false negatives. There are many ladies who have positive stress tests, but have negative angiograms because they have various other issues like coronary artery spasm and small vessel disease and so on. Further tests may be needed. This is something which people are using far too much nowadays, and that is the multi-slice CT. That's a CT coronary angiogram. There's also a calcium score, which is good as a risk assessment, but should not be used as a routine screen. And the CT coronary angiogram is not likely at any stage to replace conventional coronary angiography. It's a post-processing image, which is time and labor intensive. However, it has a very high negative predictive value. In other words, if it is normal, the chances are your arteries are normal. But there are limitations. If you have an irregular heart rate, high calcium score, if you have already been stented, and people are under the impression you do not use the contrast or dye, but you do. And radiation exposure is considerable, and in fact, it is more than the conventional coronary angiogram. The cardiac MRI will be the preferred imaging modality of the future. So this is the CT coronary angiogram, gives a lot of pretty pictures. There's also myocardial perfusion scans, as well as the MRI. These are all methods of ascertaining what kind of heart disease you have. Now, this shows you a comparison of the different screening tests. And as you can see, when you look at sensitivity and specificity, the gold standard is the coronary angiogram, where it's both sensitivity and specificity is 100%. This is a cardiac catheterization laboratory, and this is an angiogram in progress. And these are the coronary arteries, and you can see a critical narrowing in one of your main coronary arteries, which is the left anterior descending, and this is the right coronary artery. Again, it can be treated with lifestyle changes and medication. Not everyone needs to undergo a revascularization procedure, but some people do. They will need coronary angioplasty and stenting, excuse me, or coronary artery bypass surgery. Again, lifestyle changes are what I mentioned earlier. And what medications do you need? You need sometimes to decrease the workload of the heart, and you use drugs like nitrates to reduce the tendency to form clots. You use aspirin, and you reduce cholesterol and decrease recurrence of heart attacks with statins. And you can improve the heart pumping action using a drug called an AC inhibitor. Like it's the example, captopril, enalapril, ramipril, and so on. And you can reduce your blood pressure with antihypertensives. Ask your doctor about your medication and what it does and their side effects, because some of them can have rather unpleasant side effects, like a dry cough with ACE inhibitors. Now, coronary angioplasty and stenting is similar to angiography, where the procedure is where you cross a narrowed artery with a wire and a balloon, and having inflated and deflated and improve the blood flow across the artery, you implant a stent. And this is what you're seeing here is a stent. The approaches can be either through the leg, which is what we used to do, but now what is more commonly done is the hand, but sometimes you have to use the leg artery. And here you can see a cartoon of how an angioplasty is done, where having opened up with a balloon, you then pass the stent, which is really crimped on a balloon. And when you have found the best spot, then you inflate the balloon and deploy the stent and remove the balloon and the wires. And as you can see, this is a critical narrowing of the left anterior descending artery. And this is what it looks like after stenting. So the risks involved, most have no trouble at all. However, there is a risk of the artery being treated closing off during or soon after the procedure. Urgent bypass surgery in this day and age may be needed, but it's very, very rare because we have a lot of tricks up our sleeves to try and sort these problems out. And bypass surgery is an operation which bypasses the narrowed area in the coronary arteries to allow blood to get to the heart muscle. And you use conduits from your leg, like Mr. Venous vein, an artery from inside your chest, which is the internal mammary artery, or the forearm, which is the radial artery. The bypass is sewn to the coronary artery beyond the narrowed point. This is the cartoon of that. As you can see, these are sort of graphs which are stitched in beyond the blockages. And this is the real thing. And here again, you can see the graphs. And you can also see, quite interestingly, that there's this dark section on the heart, which where obviously this particular patient has suffered a heart attack in the past. So finally, heart disease is often avoidable. Following a heart-healthy lifestyle doesn't have to be complicated, and it doesn't mean you need to live a life of self-deprivation. Instead, find ways to incorporate heart-healthy habits into your lifestyle, and you may well enjoy a healthier life for years to come. So don't wait for a heart attack to take an action. Don't wait for a second life. We are not cats. Thank you.
Thank you very much, Madam, for the excellent speech on preventing heart attack. As you all know, you can send your questions through our chat box, and we will be answering and discussing all the questions at the end of the session, at the end of all 3 lectures. Next, we have Dr. Manil Kasumanitilaka, Consultant Endocrinologist, National Hospital of Sri Lanka, past President, Sri Lanka College of Endocrinologists, an overview on diabetes. Over to you, sir, Dr. Manil Kasumanitilaka.
Thank you very much, Lushanti and the CCP for inviting me today. And thank you very much for the kind words of introduction. I hope all of you can see my screen. Yes. My task has been made easier by Dr. Neomali Amarasena today, because most of the risk factors and the dietary habits that cause these, what we call as the non-communicable diseases, are the same. But let's look at few things unique about diabetes. So this Sunday evening, I'm showing you a few photographs before I actually reach the topic. This is the actual photograph in the early 1900s, number 50 Gall Road. And this is how
Manilka,
it might look.
We can't see your screen. Manilka, we can't see your screen.
Oh, sorry. Let me try again. Sorry. Now?
Still, we can't see your screen, Dr. Manilka. Try share screen.
Yeah, I tried that. Now? No?
Not yet.
Sorry. Now? No?
No. When you go to share screen, then first you will see your desktop or the screen, the whole. And
yeah,
then
which I did before.
earlier, yeah.
So I press share screen. I think Madam may not have stopped sharing her screen or something like that. She'll have to unshare or close. This happens sometimes.
No, she has stopped share, Ms. Dr. Nayanka.
Yeah, stop. Okay. So I have done the same thing which
you have done earlier, the same thing, the share screen.
Yes,
and you go to your
yes.
icon and then open your slides.
No, I can see it there and it's coming on now. No.
No.
If there is a problem, Manilka, may I suggest that Chandimani takes over now, and then you can join in as the third speaker. Is that okay, Chandimani? Is it possible for you to go start yours?
Yeah, sure, no problem.
Yeah, sure.
Please.
Dr. Manilka, why don't you leave the call and join back again in the meantime?
Okay, right.
Okay, then that might sort out the problem.
Okay.
Okay, so I would like to invite Dr. Chandimani Undugodage, consultant respiratory physician and senior lecturer, University of Sri Jayawardenepura, President-elect, Sri Lanka College of Pulmonologists, to deliver her speech on asthma. Over to you, madam.
Okay, thank you very much, Lushanti. And may I start by thanking the Ceylon College of Physicians for inviting me, and also the Bar Association for hosting this event. So I'm going to talk about our asthma. So I thought I'm going to talk the very basics of asthma, and I thought I will start by telling you a little story. So this is about Charit. So Charit is a 40-year-old lawyer, and he has a dry cough going on for 6 months. Now this is an intermittent dry cough, which is worse in the morning. And he coughs when he talks for a long time or when he laughs. He feels quite embarrassed by this. And lately he has noticed that he gets breathless when he climbs a flight of stairs. And sometimes he wakes up from sleep feeling tight in his chest. He had wheezing as a child, but doesn't think that he had asthma, and he is well otherwise. He has gone to several doctors, but they all wanted him to take inhalers, but he doesn't think he needs it. And besides, he doesn't want to get addicted to inhalers. So this is about Charit, and Charit has asthma, and this sort of a scenario we see quite often in our day-to-day practice. So over the next 20 minutes, I like to take you over asthma, and then I hope to answer these 5 questions. So first is, what is asthma? Then, what are the symptoms of asthma? What triggers asthma? What makes asthma worse? How do you diagnose asthma? And how do you treat asthma? The very basics. So let's look at what is asthma. So before I start about what is asthma, let me just tell you a little bit about the respiratory system. So asthma is a disease that affects our respiratory system, and respiratory system is what we use to breathe or take oxygen inside to the body and breathe out carbon dioxide. So if we take our respiratory system, it actually starts at the nose. So through the nose, you have what we call the nasal cavity, and then from the mouth, you have the oral cavity, and these two join together at the back of our throat, which we call the pharynx. And further down, the pharynx divides into 2, and there's one part which leads to the larynx or the vocal cords where your voice box is. And further down, you have this long tube, which is called the trachea. And this trachea divides into 2 bronchi, which goes into the 2 lungs. So if we really take a look at what our lungs are, so these bronchi, they go on dividing into teeny tiny airways. So what we call these little tubes. And these tubes go on dividing and dividing and dividing. And finally, they end up in what we call alveoli, or that's where the gas exchange actually takes place. So if we take all these airways together and the alveoli together, and we cover it with a membrane, you get your lungs. Now, what is the relationship with asthma with all of this? So asthma is a disease that affects your airways, so which means your little bronchioles. So all those tiny airways that actually takes oxygen into the lungs or into the body gets affected in asthma. So if you look at the image on the right side, you can see I have shown three tubes. These are cross sections of the airway. So the first one is a normal airway. So you can see the lumen, which is nice and open. and there is a little bit of muscle around it. And so through this tube, you have air going in and coming out. Now, the next one is an airway of somebody who has asthma. So there, if you look at it, you can see the first thing that you will see would be that the lumen is narrow. So they have narrow lumen. And if you look at their muscle wall around it, it's a little bit more than of a normal person. Now, asthma patients, somebody with asthma, they don't have symptoms all the time. So when they get symptoms, and if you look at their airways, that will be what is shown on the cornermost image. So there, the lumen is really narrow, and there's very little space inside to take in oxygen and put out carbon dioxide. And if you look at the wall, you can see the muscle bands have become really tight. So in a nutshell, so asthma is a disease that affects our airways, and basically they make our airways narrow. So what are the symptoms of asthma? So in asthma, there is airway narrowing. So one of the first symptoms that somebody would experience would be a cough. Now this is a dry cough. Now sometimes some people get cough with phlegm, where they are producing a lot of phlegm, and that is not the cough of asthma. Cough of asthma is very dry, and then you get it intermittently. At the initial stages, the patients experience cough, particularly in the night or in the early morning. And there is a reason behind this. In all of us, our airways have what we call a circadian rhythm or internal body clock. Our airways are not the same size throughout the day. They become narrow, they open up. But in a normal person, even when they are a little bit narrow, they function well. That narrowing is enough to take in air and take in oxygen and bring out carbon dioxide. But in an asthma patient, because their airways are already narrow, even a little bit of narrowing, further narrowing gives rise to symptoms. So in our internal body clock, even in a normal person, towards the latter part of the day or late night or early morning, all our airways become narrow. So at that point, a person with asthma who already has narrow airways will experience symptoms. So they will get a cough, they wake up with cough, or they feel tight in their chest early hours in the morning. And some people experience symptoms after exercise. So they don't have symptoms at any other time, but when they run or they do something or they do some activity, then they become breathless. They say they are fine, they go to the gym and they're on the treadmill a bit, and then they get very breathless. So there is patients with asthma can have exercise-induced symptoms. And there is another category called exercise-induced asthma, where they get symptoms only during exercise. So that is one group of people. And the other thing is people who get cough when they laugh. So you may have noticed in a group, somebody cracks a joke and everybody laughs, and you see this one person who starts to cough. So that person has airway disease. So these are the subtle symptoms which are there initially, which people tend to ignore. Later on, when they have a lot of symptoms, they can get wheezing. Now, wheezing is this musical sound that comes from the chests of patients with asthma when they have worsening of symptoms. This is because when their airways become narrow, when the air goes through that narrow tube, the air flow, which is normally a silent flow, what we call a laminar flow, becomes turbulent. So when you listen, you hear the noise. It's a very musical noise. And some patients, when they have a wheezing episode, and when you listen to their chest, you hear an entire orchestra playing. So it can be quite loud. And sometimes you can actually hear it while you are sitting and talking to the patient. But in some instances, when the asthma becomes really worse and when you listen, there is nothing. So that's what we call a silent chest, and that's when they are in a critical stage. So initially, they can also experience chest tightness. So imagine, I told you have all these little airways, all these bronchi in their chest, inside their lungs. And when they all go into spasm, when they all constrict, they feel really tight. And all of this will give rise to shortness of breath or breathlessness or dyspnea. So all this, that they experience much later. So all of these are the some signs and symptoms of asthma. So what is very characteristic about asthma, which differentiates from other respiratory diseases, are the intermittent nature or the episodic nature of these symptoms. So somebody with asthma, they get cough or wheezing or whatever at a particular time or over 1 or 2 days, and then they're perfectly all right. So this is intermittent nature. This is in contrast to some of the other diseases, respiratory diseases that present with cough and wheezing. And then the other one is characteristic triggers. So there are certain things that brings about their symptoms. Now, if you really talk to the patients, they have already identified these things. I will talk a little bit more about triggers later, but there is something like that. Then there is another condition called work-related exposures or occupational asthma. Now, this again is very important because these patients, they tend to develop symptoms while they're at work. And the reason behind is they may be exposed to something, some toxic gas, or they may be inhaling some dust particle or something, or maybe there's a strong perfume in their office, or they have used an air freshener, something like that, where they get symptoms while they're at work, but they are free of symptoms when they're at home. So this is what we call occupational asthma. Then the personal or family history of atopy. So what is atopy? Now, atopy is a condition which runs in families where these people have a lot of allergies. So there are allergies to various food items, and then at the same time they have eczema. Eczema is a little rash that people get, especially in childhood, over their ankles, around their elbows and knees. And then they are allergic to many things. So these are the group that we refer to as atopic individuals. Now, people who have atopy also have the tendency to develop asthma. That puts you at a risk of developing asthma later on in life. And childhood asthma. So if as a child, if somebody has had wheezing, or they get a little bit of wheezing when they get a common cold, or they've been a chesty child, then those are the asthmatic symptoms. So if you had asthma or those symptoms as a child, there is a chance that you can get asthma in adult life. So let's try to look at the third one. What are the triggers of asthma, or what makes asthma worse? Okay, so these are the important triggers of asthma. So patients, when you talk to them, we should always try and find out what triggers their asthma, because we can ask them to avoid the triggers. As long as the trigger is there, it will be very difficult to control their asthma. So one of the commonest trigger for asthma is the house dust mite. Not everybody with asthma is triggered by house dust mite, but it is the commonest. And if that is your trigger, then you are actually in quite big trouble, because house dust mite is everywhere. That is a little mite that lives in the dust, and it is there on top of the cupboards, amongst your clothes, on upholstered furniture. It is extremely difficult to get rid of the house dust mite. So that is one of the commonest triggers. The other things are like cockroaches and various other pests that you get in the house. Certain people, that is also a trigger. Then another one is smoking. Smoking triggers asthma, both active smoking and passive smoking. Active smoking is when you smoke yourself. Passive smoking is you are subjected to smoking because somebody in the household is stupid enough to smoke. Now, I know Dr. Amali spoke a lot about smoking, so I will not go into the details of harmful effects of smoking, but I just want to say one thing. Not only does smoking triggers asthma, now when we treat asthma with our medication, the inhalers, the smoking actually reduces the effect of those inhalers or the medication that we are using for asthma. So that's another downside of smoking. And pollen. So in certain times, this we see especially in the West, where they have 4 seasons going on. In the spring, people with asthma, they have a lot of symptoms. That is because of the pollen that is generated from the trees, the buds that are coming into life now, and that can trigger asthma. And interestingly here, now in changes with weather, asthma can get worse. So especially people come and tell us that during the rainy season, when there is rain, they get asthma, what we call thunderstorm asthma. So it is actually very interesting. It has nothing to do with the rain. What it does is during this rainy season, you have a lot of mushrooms coming up. So these mushrooms tend to generate spores. And the spore burden in the environment becomes very high during that time, and that can trigger asthma. And also people say when they go and have a wash or have a bath, that tends to worsen their asthma. So again, several reasons there. One is the mold that is in the bathroom can worsen asthma. And whatever the products that they are using on their body or shampoos and things like that, if they're allergic to a particular chemical in that, that can worsen asthma. And the cold air can also precipitate asthma. That's why people, when they go in the cold, they get symptoms of asthma, because the cold air can cause airways to narrow. And certain strong fragrances and things like that can worsen asthma. I have had a patient who actually gets symptoms on his way to work, and he doesn't have any symptoms otherwise. So later on in the history, what we realized was the air freshener that he has in the car is really what is bringing about his symptoms. So generally, if you talk to when we talk to the patients, we can actually find out what their trigger is. And pets, cats and dogs, especially cats, people who are allergic to furry pets, then they can get, their asthma can get worse when they're exposed to the pets. And also colds. Now, a lot of people, when they get a common cold, their asthma can get worse. So again, anything that gives rise to their bronchi narrowing will give rise to symptoms. Then finally, strong emotions, getting angry all of a sudden, stress, all these things can worsen asthma. I want to talk to you about two things. These are called asthma-associated conditions. Now, these are not triggers of asthma. These are two disease conditions that go hand in people with asthma, and that they tend to make asthma worse. One is allergic rhinitis, or what we call hay fever. Now, these are the people from when they wake up in the morning, they start to sneeze, they have runny nose. It is not COVID, they have it every day, and they have itchy eyes and itchy ears. So this is hay fever. People with hay fever, unless we treat the hay fever, their asthma is just not going to get any better, because asthma, if there is problems with the nose, I told you it is one respiratory system, is one unified airway. They would obviously have symptoms down below as well. The other thing is gastroesophageal reflux disease. Now, gastroesophageal reflux disease is of a system to completely away from the respiratory system. But as like the name implies, so gastro is stomach, esophagus is the food pipe that joins from the mouth to the stomach. Reflux is it is going back. So you have acid in the stomach going into the esophagus. So one of the things with gastroesophageal reflux disease is that it gives rise to a cough. And some people, they have what we call laryngopharyngeal reflux, where their acid actually goes up the esophagus and which precipitates a cough and which can worsen asthma. So always in somebody with asthma, whether they need to be treated for these two conditions if they have symptoms of asthma, otherwise their asthma just won't get better. So fourth one, how do we diagnose asthma? So asthma is basically a clinical diagnosis. So when we talk to a person with asthma, we know it is very easy for us to suspect asthma, especially when I talk the symptoms I told you. And also if there are no other symptoms. Now, what do I mean by that? In somebody with asthma, they should not have any fever. If there is fever, it is not asthma. If they are producing phlegm with the cough, it is not asthma. If their appetite is lost or if they are losing weight, then we are not dealing with asthma. So asthma is in a perfectly normal person if you have cough and wheezing and shortness of breath. And we do certain investigations as baseline tests, mainly to exclude anything else. Now, for example, we do a chest X-ray. We expect the chest X-ray to be normal in a person with asthma. Just do it to exclude any other condition. And we do blood tests, like we do a full blood count and we look at their eosinophil count. Eosinophil is this cell in the blood which goes up in allergic conditions. In asthma patients, it's a little bit high, but if it is very high, then there are other conditions that are called asthma mimics, where they have wheezing, but they basically have other eosinophilic lung diseases, not asthma. And we also do a ESR, and then that is to see whether there is any infection in the body. That should also be normal in asthma. With this, we can actually diagnose and start treating asthma. But we also do something called a lung function test. As the name implies, it assesses the function of your lungs. We see how well your airways are, and whether there is any narrowing. So in a patient with asthma, what is the classic feature is this narrowing is reversible. So when we do the lung function test, we would also give a little medicine in between, and we look to see whether the airway narrowing is reversed. So if the airway narrowing is reversed, that means if we can make the airways normal by giving that medication, then that is asthma. In certain other airway diseases, it is not reversible. So these are the tests that we do in order to diagnose asthma. So last question, how do we treat asthma? So I have to say, inhale, this is one of the, so in olden days, people who had asthma, they suffered a lot. They had a lot of wheezing, they were coughing all the time, and they had a lot of problems. And what really revolutionized the treatment of asthma, this happened many years ago, was the inhaled corticosteroids. Inhale, that is because we are giving it through an inhale directly into the lungs, and it is corticosteroids. Now, steroids, you must have heard already, prednisolone and various things. Now, these steroids in asthma, we are using it directly onto the lungs. So there are very minimal side effects. It is not like taking oral steroids. When you take oral steroids, other than the beneficial effects, you may have heard of side effects like diabetes or blood pressure going up or affecting the bones, affecting the eyes. But in asthma, we use very small doses. We use micrograms, and it is given as an inhaler, where it is given directly to the lungs, so that it goes directly into the airways. So this really made a difference in the treatment of asthma. It really reduced the deaths in asthma, because asthma is a disease that can kill, and there are many deaths because of asthma. But by using an inhaled corticosteroid, we can really reduce the disease mortality, that means the death rates, as also the symptoms and morbidity. That means they can be really well. So this inhaled corticosteroids is what we use, and we give it every day. Now, the way we give it, there are two types of inhaled inhalers. Those are the dry powder inhalers and the metered dose inhalers. The dry powder ones are like a little powder which comes in a capsule. So the capsule is put into a device, and you take it into your mouth and inhale, and the capsule breaks and the little powder goes into the lung. So those are dry powder. Certain dry powder inhalers do not come with a capsule. They are just loaded onto the inhaler device. But again, you take it the same way. So those are easy to take. As you inhale, the powder also comes, and then you just hold the breath for 10 seconds, breathe out, and done. So you have to obviously wash your mouth, gargle, and spit it out. Now, metered dose inhalers, like what I have shown in the picture, are two sprays where it generates a spray. So when you take it into your mouth and just spray it into your mouth directly, what happens is it's very difficult to coordinate with the breath. The spray just goes and hits the back of the throat. So generally these are prescribed with a spacer. So you give the spacer. The spacer is a little device like a ball. So you put this inhaler onto the spacer, give a squirt. So this the vapor or the air goes into the space, and through the spacer you can take a breath in, hold the breath for 10 seconds, and then breathe out. And always wash and gargle and spit out. So that's how you, those are the two main types of inhalers we have, and that is how we take it. Now the inhaled medication, we have relievers and preventers. Now inhaled corticosteroids are the preventers. So that is, preventers means that will prevent you from getting an episode later on. So once you start taking the inhaled corticosteroids, it takes about 2 weeks to act. So you take it every day, morning and evening, like a prayer, you have to take it. And you do not get addicted to this inhaler. You may not see an immediate benefit of this inhaler either. So which is why some patients, they tend to stop using it. But actually, this is the more important one out of the two. The other one is a reliever. So most of the relievers are generally comes in the color of blue. These are short acting ones. So as soon as you take it, you feel a benefit. It lasts for about 10 minutes and it goes off. So a lot of people, a lot of patients, they like the reliever because they take it, they get a benefit. Unfortunately, reliever is short acting. It doesn't do, it just makes your airway a little bit bigger at that particular time. The symptoms go away, you feel fine. But it doesn't really work on the airways and prevent it from going into another episode later on. Now, inhaled corticosteroids are actually preventers. So that is the important one when it comes to asthma management. And inhaler technique is also very important because however much we prescribe the inhaler, if the patient is not taking it properly, then there is no benefit. Actually, the responsibility to make sure that the patient is taking it properly is in our hands. So at every visit, we always get the patient either to demonstrate and show us the inhaler technique, or we have a separate person who does goes and teach in the clinics. Clinics are very busy. So there is a person there who goes on demonstrating and making sure that the inhaler technique is correct. So this is really the basic treatment of asthma. I'm not going to touch upon all the other management strategies and manage methods that we have, because I think for the general public, it's just important to understand the importance of this preventer and the reliever. So what I really want to highlight is using a regular inhaler will really keep asthma symptoms at bay. And a person with asthma can lead a perfectly normal life, because asthma, unfortunately, is not a disease that can be cured. So if you have asthma, you will always have asthma. It is like diabetes and high blood pressure and all that. There's a lot of patients, they come to us and they ask whether this is going to be cured. The answer is no, but still, just because you have asthma, that should not prevent you from any activity that you are doing. And then by using a regular inhaler, will really keep the symptoms at bay and you can lead a perfectly normal life. So one other little thing that I really want to highlight would be children with asthma. It is very important that children with asthma are identified early and are adequately treated, because I find it is very sad. Sometimes the children are not given the inhalers, the mothers don't give it, and then the mothers are worried that the child will get addicted, so they don't give it. And these children, because of the asthma attacks, they miss out on school, they miss out on classes, they miss out on their exams. So they really sets them back in their life. So it's very important, and this is a disease that can be easily controlled. So it's very important that that a regular inhaler, that an inhaler is taken every day to keep the symptoms at bay. So that really concludes my talk. So I try to answer 5 questions. So what is asthma? It's an airway disease where there is narrowing. What are the symptoms of asthma? So we know cough, wheezing, and intermittent symptoms. What triggers asthma? I think we talked a lot about the triggers. How we diagnose asthma? It's a clinical diagnosis. And how do we treat asthma? Basically, inhaled corticosteroids every single day. I will stop there, and thank you very much.
Thank you very much, Dr. Chandimani Udukuduge, for the comprehensive lecture on asthma, especially explaining everything in simple language. I would like to again remind you about questions. If you have any questions regarding heart disease, asthma, you can send your questions to our Q&A box or chat box, and we will answer all the questions at the end of the session. So we are moving to our last lecture for today. Next, we have an overview on diabetes. Dr. Manil Kasumanitilaka, consultant endocrinologist, National Hospital of Sri Lanka, past president, Sri Lanka College of Endocrinologists. I hope we can start the lecture on diabetes without any interruption now. Over to you, sir.
Let's hope for the best. I hope everybody has logged out from the screen. So I'm going to share my screen now. Am I there?
Yes, you're there.
Okay, fine. So being the last man out, and I have about only 15 minutes left, and after a lot of, I think all of you have learned a lot of new things, facts. Let me take you through few photographs. As a picture paints 1,000 words. Let's see. This is Gall Road, Colombo 3, number 50 Gall Road in early 1900s, and how it might look today. And these two people have gone hunting for their food and killed the animal, and they're preparing the food. That this might be the only protein that they get for a couple of days. And in contrast, today's lifestyle, all this food can be bought in 10 to 15 minutes, maybe a month's supply if you get into a supermarket. And what happens? Today's lifestyle, we indulge in lots of energy-dense food, I think, which Dr. Neomali Amarasena had made my work easy. She alluded to all this, and all this leads to obesity. So why am I talking about obesity in diabetes? So obesity is measured as shown here with the body mass index. You can, looking at this, you can get your BMI counted very easily, weight divided by the square of your height in meters, and there are different values given. So if you are about 25, you are overweight, and if you are about 30, you will be obese. It's so common, type 2 diabetes and obesity. You know, the diabetes, when we say the commonest type in the world is type 2 diabetes, and obesity is so closely linked. That's why I started my lecture with these few slides. And some have coined the word diabesity in the sense, because that is the underlying problem when it comes to heart disease and diabetes and other non-communicable diseases as well. As you all are very familiar with these balances, we know that how obesity happens and all the NCDs occur is when you consume more calories than what your body is able to burn. So the excess is mostly stored in your body, in your tummy and around your internal organs as fat, which is the problem in most of the heart diseases, as Dr. Amarasena showed before. And it also increases the risk for diabetes, which I call as the evolution of the modern man. Some people say it runs in the family. She answered that. It's not the genes that has caused this exponential rise in diabetes in the world these days, the type 2 diabetes. It's the changing lifestyles, consuming more energy-dense food and less exercise, causing obesity has caused this, what we call as the pandemic of diabetes in the world today. So what is diabetes? So this was described by a Greek physician, which means passing water through a siphon, and mellitus is the word sweetened with honey. So in very simple terms, it basically means abnormally high blood glucose or sugar levels in a person's blood, which is long lasting, not a transient rise, which causes the problem of diabetes. So it's a mixture of Greek and Latin words: to pass water like a siphon, and then sweet as honey. So how ironic, two civilizations in India, they call it Madhumeha, same meaning, sweet urine. And Diya Vadiyawa in Sinhalese also is the same. So it's looking at the main symptom of the disease that they have coined the word diabetes mellitus. So when we say diabetes, it's the type 2, which is seen in 95% of the time in most of the people. But there are other types of diabetes, as you know, in children as young as 8 or 10 years, they can get diabetes, or even younger than that, where they don't produce any insulin, which is called as type 1 diabetes. And then during the pregnancy, we get gestational diabetes. And there are genetic defects. A single gene defect can cause diabetes, which are very rare, 1% of the time, which is called as MODY. And there are other endocrine disorders like Cushing syndrome, acromegaly, where you get to gain weight, and certain medication, steroids, and other drugs which can cause the sugars to go up. And even certain viral infections can cause autoimmune diabetes. So many causes, but the vast majority, 95%, would be type 2 diabetes. I don't want to bore you with a lot of physiology, but just to give you a very basic idea what happens in diabetes. So as you know, the pancreas has beta cells, which produces this hormone called insulin, which is the main regulator of your blood sugar or the blood glucose levels. So what insulin does is it acts as a key to open the doors for the glucose to enter your liver, the fatty tissue, and the muscle. So in these organs, they are converted into different compounds, and they are stored as glycogen or fat. And the levels in the blood goes down. In diabetics, when there is no reduce in the production of insulin, or insulin is there, with obesity, the insulin does not work properly due to the fat, what we call as insulin resistance. So when that happens, the glucose will not enter the organs as efficiently as in a normal person, and we say that there is increased blood glucose and you get diabetes. So what are the symptoms? Very briefly, I have explained, the name itself is explanatory. You pass a lot of urine, and you feel thirsty, excessive thirst, especially at night. You tend to pass water, and unintentional weight loss, sudden onset. Then non-specific symptoms like excessive hunger, drowsiness, numbness in your hands or feet, or blurring of vision. All these things, one or two symptoms together, could mean that you may be having diabetes. So how do you diagnose the condition, which is shown here? It's a very simple test, 8 to 10 hours of fasting, and then you do what you call as a fasting blood glucose, or a FBS, as we call it, fasting blood sugar. And if the levels are more than 126 milligrams per deciliter with one of those symptoms, then we can straight away diagnose diabetes. But if you don't have symptoms, you must repeat the test, and then if it is still high, we can diagnose diabetes. If you are below 100, you are good, completely normal. If you are between 101 and 125, we call it as pre-diabetes. So you are borderline, and there's an increased risk of getting diabetes in future if you don't modify your lifestyle. What are the problems associated just having high sugars? If you have those symptoms, when you lower the sugar a bit, those symptoms disappear. And in people who have had diabetes for a long time, even if your sugar levels go up, they are sort of conditioned for that, and they don't get those symptoms I mentioned before. But this is a silent killer. We call it a silent killer. And Dr. Amarasena has very nicely showed it to you how these arteries get clogged and gets damaged. What diabetes does is it lays the foundation and exacerbates the process of what these blocks happening, and the way she showed. So a diabetic is 2 to 3 times more prone to get heart attacks or strokes, and there are increased risk of having nerve problems, and which ends up in amputations with chronic wounds. They are more prone to get kidney problems and complete kidney failure, or we say as end-stage renal disease or blindness. So these are the major problems, complications associated with diabetes. How do we prevent that? That's the most important thing. Prevention of diabetes is simply living according to your genes. What are the genes? I have shown some pictures. So what the people say is we still have the hunter-gatherer sort of genes where we are expected to, do a lot of physical activity for our good health, which is not happening. Over the past 40 or 50 years, there has been a sudden change in our lifestyle, which our genes are not matching. So that's why this mismatch is happening, and we are gaining weight, expanding waistlines, and the problems associated with diabetes and other heart problems. Eat according to your energy needs. I showed you the balance. If you eat too much, the rest will deposit as fat. Lead an active lifestyle and prevent obesity. Like heart problems, you can prevent diabetes. If you get diabetes by any chance, then the managing diabetes is also important, and it's a disease which can be very well managed, and all people with diabetes can lead a normal, happy life if you don't neglect yourself from the beginning. So diet is the number one. No latest medicines, insulin or anything is going to help if you don't stick to a proper diet. Exercise would be number two. Then all the other oral medications or the tablets we have to manage diabetes is number three. And if everything fails, then insulin. I'm talking about type 2 diabetes here. In type 1 diabetes, it would be insulin would be the first choice after diet and exercise. Food, I'm not going to talk too much. You have listened to a lot about healthy food. You know which side to choose. Energy dense, fatty food and high calorie food should be avoided. Eat plenty of vegetables, moderate amount of fruits, a moderate amount of protein, and fiber rich carbohydrates and foods would be the way forward for a diabetic to have a healthy life. Quantity is also very important. Some people say, I am having kurakka and still my sugars are high. They don't control the portion size. So this is a method that was used especially in Africa, where they have shown the quantities, the relative quantities of each component of food that you should have. So this works well in Sinhalese. If I may, I'm sorry if somebody doesn't understand, but I would say Attamita Molavala Piti Ahara, Dota Pura Elavalu, Alla Pirena Taramata protein, Angille Taramata tel. So this goes well. So you got the quantities, fish full of carbs, closed fish full of carbs, and lots of vegetables and protein in moderate amount and a small amount of fat for a meal. The plate method might be easy for somebody. The Canadian Diabetes Association, of course, recommends only a quarter plate of carbohydrate or rice for a meal. But in Sri Lanka, at least with our culture, our compromise is at least half would be the maximum for lunch. Dinner and breakfast, if you are having rice, it should be or pasta, a quarter plate, and the other half should be full of green leafy vegetables and other vegetables and your protein. Of course, it's a balance again. I have used few balances because of the audience. You are also familiar with this. So it's a choice that you make for a healthy lifestyle and a life without complications in diabetes. You choose the right side and have a balance in life when it comes to food. So people ask what's good and what's bad. It's a continuum, I would say, depending on what we call as the glycemic index. So you should learn to read the labels in the food, which gives the calorie amount of carbs, and know about the little bit about glycemic index, because that helps. there is no food that you really can't take at all in diabetes, or there is no food that you can indulge in always. So you look at the glycemic index, choose the low glycemic index foods more often, and only occasionally you can have the high glycemic index. So it's a index where what it shows 100 grams of that particular food. If you take it, what is the level of blood glucose rise in your blood? So it gives a relative amount of carbohydrates or the sugar in these food items. I hope you all will save me if the manufacturers of this, I have covered the labels, but still you can recognize. Read the labels, but sometimes you might not understand the gravity of the situation, the amount of sugar. These are actually done by a nutritionist. In each of these popular beverages, you can see the amount of sugar in it. 1 teaspoon would be about 5 grams. So you can see a 1.5 liter bottle of this beverage, how much sugar you'll be consuming. So just having a fruit juice or a drink or a energy booster will be detrimental sometimes in a diabetic. So what's the ideal diet for a diabetic, which is important for you all, and this is good even to prevent diabetes. If you have pre-diabetes, it should be simple, measurable, achievable, realistic, and time-bound. Realistic for that person and the profession, and achievable looking at his social status, his work schedules, all that. We have to take all that into account. Crash diets won't work. Little changes over a long period of time will do better than a crash diet or a New Year resolution for 2-3 months. By March, it's done away with. It's not going to help. Exercise is the next best way to treat diabetes and prevent diabetes. Children need at least 1 hour a day, and adults half an hour a day, 5 times a week. Exercise of your choice according to your ability you should do, and we should inculcate good habits in our children from their young days, the exercise culture. And of course, you and I will say we don't have time. The chamber time, codes, our channeling, all that is a problem. But during our work, you could do something to get your daily quota of exercise. Park your car probably away from Halsdorf. Take a walk after work, or take the stairs instead of the elevator. Take your dog for a walk. These things can be done easily, and you get your daily quota of this thing. But of course, Sri Lankans and others try to take shortcuts. So please don't walk your dog like this, or use your treadmill for things like this. In Sri Lanka, I don't have audience to ask, but the commonest thing what we do is we hang clothes in all our treadmills rather than using them. Some people say, I exercise, I do my cycling, I go around the Independence Square 5 times. So that's why I'm having my favorite pizza, or my Oreos, or your chocolate biscuits, or your can of Coke. So look at the scale of things. This is not all our food, but just look at the scale of things. If you have 2 pepperonis, then 560 calories, you'll be cycling for 65 minutes. If you have a can of Coke, you'll be walking for 23 minutes to burn that. If you have 2 Oreos, or maybe our chocolate biscuits, you'll be doing some weightlifting for an hour. So it's impossible to burn all what we take in, to burn the calories and neutralize, unless we control our diet. So that's the message I have from this slide. When these 2 fail, we have armamentarium of 11 groups of medication, which is approved for diabetes. And we have, apart from 2 or 3 of these groups, we have everything in Sri Lanka. And you might wonder why sometimes we give 2-3 types of medication. So these drugs, like the metformin, works mainly in the liver. Then we have the glycoside, or the glycoside MR, which works mainly in the pancreas to increase the insulin secretion. There are drugs which inhibits the absorption of glucose from the intestine. And then there are other drugs which will reduce the insulin resistance. So we combine match and combine different types of drugs which works in different ways in a synergistic manner. So that's why we gave sometimes a combination of medication. Those who have diabetes might know that the HbA1c is a good marker of your control, 6.5 being a good target, but even 7 is reasonable. By reducing, even if you have a level of 9%, if you bring it down to 8%, you can reduce the risk of death by 21%, risk of kidney and eye problems by 37%, and heart attacks, or what we saw before, by 14%. So that's the scale of thing. So if you reduce it by 2%, double the benefit. Coming to, for people who have diabetes, so to control your blood sugars, we would say fasting should be anything around 80 to 120 or 70 to 130. Different associations give different values, but in Sri Lanka, generally we take it as 80 to 120, and 2 hours after a meal, anything between 140 to 180 is okay. Younger you are, no other complications, it should be at the lower end, 80 and 140. More elderly with more other problems, heart failure, cancers, any other issues, 120 and 180. So that's the equation. That's why we give a range. And the HbA1c, the 3 months average, anything between 6.5 to 7 would be good. Insulin therapy, if everything fails, I'm not going to talk much about it. It's nearly 100 years of insulin. It was last year, which was a life-saving drug in 1921. Children used to die of diabetes, type 1 diabetes, discovered by these two gentlemen, Banting and Best, and how the body produces insulin when it is functioning well. With a meal, the levels go up, and then you need a basal level, which is even during your sleep, the liver produces sugar. So some people might say, I have skipped dinner, but my sugars are still high in the morning. That is because you are lacking insulin, and liver is producing insulin during your sleep. So you need insulin to control that in people with type 1 diabetes, and eventually even the type 2 diabetics. After 10-15 years, sometimes the tablets fail to work. Then they also will need insulin to control their sugar. Multiple daily injections is the norm these days, but technology is there. Unfortunately, at the moment, we don't have it, but there are insulin pumps, a small gadget to wear in your waist, and it will continuously give you insulin supply throughout the day. And we have gone even further, creating what we call as artificial pancreas, where we have a sensor here. We measure your sugar levels, and when it goes down through Bluetooth, it will stop the pump if the sugar levels go down. And we can get a reading onto your phone and get an average of the blood sugars for the day. So this technology is also available. I think this was shown before. Vast number of our diabetics die due to cardiovascular problems, strokes and myocardial infarctions. And they don't die. People who have diabetes alone is a minority. Most of them have diabetes, hypertension, and cholesterol all together. As you can see in this chart, 56% of our patients will have all three. So just controlling sugar won't do. You have to stop your smoking, control the blood pressure, and control your cholesterol. And if you need to go look at the values which were mentioned before as well, you could look at this chart. So when you are a diabetic, compared to what Dr. Amarasena said before, your cholesterol level should be even lower. So we would recommend a total cholesterol of less than 160, LDL less than 100, or if you have heart problems with diabetes, your LDL should be further low, below 70, the bad cholesterol, and the blood pressure should be less than 130/80. So it's beyond glucose control, can save lives and make you be able to have a happy life with diabetes. Thank you very much.
Thank you very much, Dr. Manil Kasumanitilaka, for addressing very important aspects of diabetes. So, as you all know, we had 3 important lectures on heart disease, diabetes, and asthma. We have some questions through our chat box as well as the Q&A box. So I would like to ask few questions as we have now taken more time on explaining our diseases. So first I would like to ask Dr. Neomali Amrasena. Madam, there is a question on exercise after coronary artery bypass. If you can explain about the exercises after bypass surgery as well as heart attack, what are the things that they have to consider when we are starting exercises, and what are the limitations on commencing exercises?
Yes, actually, I did answer that particular this question earlier on the chat box. But when it comes to bypass surgery, you will find that when the patient is out of the intensive care unit, the exercise program starts from that point, where the physiotherapist will be getting him to do certain types of exercises, you know, to get his limbs going, and also particularly they have to blow into certain machines so that their lungs expand. You know, it's a total thing. It's not just only your exercise. You see, there's physiotherapy involved, and the physiotherapist also will be teaching the patient how to do certain types of exercise. So it is what is called cardiac rehabilitation. And actually, many of the hospitals have got the cardiac rehabilitation setups quite well sorted out, where they have to come and then they are put on treadmills and various other machines, and they are also asked to do certain types of exercises to make sure that they are that they get back to normal fast. Now, once all that is being done and they are finding that they're quite okay, they can start their walks. Now, actually, the walking starts quite early in the day, including when they're in hospital, because they are even taken up several flights of stairs. So it goes alongside the physiotherapy. So the walks are really just a normal walk where you walk on a flat surface and you try to do about half an hour a day. So it varies from person to person. You see, all people are not equal. The younger people naturally get on their feet much faster. Those who have arthritis will find it difficult anyway to walk. So each one has to manage as best as he can with whatever his limitations, but try to aim at that half an hour or 30-minute walk. And that when it comes to angioplasty, it's the same. When it comes to anybody, it's the same. What we recommend is a 30-minute walk.
Okay. And one more question to Madam about medications using after a heart attack. So people tend to stop their medication without doctor's advice. Is it important to continue their medications until they were given proper advice?
Yes, you see, the thing is, once they've gone, especially if they've undergone something like a bypass operation, they sort of really feel that now it's time to throw away all the tablets. You see, they have gone through so much. I mean, they've been swallowing tablet after tablet earlier. They don't realize that most of these tablets are really for risk factors. And all we are giving for the bypass are it really happens to be aspirin and the clopidogrel or whatever the other antiplatelet drug is. Because if they're diabetic, they'll be on a plethora of drugs for diabetes. If they're hypertensive, that has to be controlled. The cholesterol has to be controlled. So you will generally find that most of the prescription really consists of drugs which are there to control the risk factors to prevent them from getting another block. Because what most people don't understand is that both angioplasty or stenting or bypass operations are merely plumbing jobs. The real cause are the risk factors. And so the thing is, however good your plumbing is, if you don't continuously keep your tubes in good shape, well, they're going to block again. And that is what happens. So the thing is, people, what they say is that, I mean, after spending about $1 million on a bypass operation, they feel it's pretty unfair that they should really get another block. But they have to do their bit as well. You see, they have to control their risk factors. They have to follow that. And we do tell them to do so. But what they do is they actually dodge coming for any kind of follow-up. And suddenly you find them surfacing about 5 years afterwards with angina again. And they're thoroughly upset that some of those grafts are blocked off.
Thank you very much. Thank you for that explanation, Madam. Next, I would like to ask Dr. Manil about diagnosing diabetes. There is a test called HbA1c. That test is used to diagnose as well as to monitor the sugar levels. What is the importance of using this test?
Yes, Thank you very much. I think I didn't mention that. HbA1c above 6.5, you can diagnose diabetes. HbA1c of 5.8 to 6.4 would be pre-diabetes internationally. But as you know, in Sri Lanka, as the College of Endocrinologists and the physicians, we have agreed that we are not, and the ministry has agreed so far not to go by the HbA1c to diagnose for the very first time somebody, because our labs have an issue, because this HbA1c is a very sophisticated test, and you have to do what we call as the gold standard, very expensive machine, which is still not freely available in our health system. So there are other methods which are less sensitive, or it may vary. So that's the reason why I didn't mention we can't make a diagnosis, but it's a good marker to monitor the disease. And of course, if I may tell all the Colombo labs, if you use the HPLC method, all the leading Colombo labs, they are fine. You can use their reports to diagnose, but not throughout the country. So 6.5 is the cutoff.
Yeah. One more question, Dr. Manilka, because when we talk about medicines used for diabetes, metformin is one of the oldest, as well as most of the time we use metformin. But people used to ask that, is there a risk for kidneys using metformin for a long time? This is a very popular question.
Yes.
Yeah.
So there are,
what do you think?
As Dr. Amarasena mentioned, it's all, the misconceptions in society. That's what metformin was discovered in 1958. So it's after insulin, the oldest medication we have for diabetes, and anywhere in the world, from Europe to North America to the Asia, #1 drug, first choice of medication in diabetes. It has absolutely no renal effects. But if you have high sugars for a long period of time, that can affect your kidneys. And if your kidneys are affected due to diabetes or any other reason, high blood pressure or any other reason, the metformin is also metabolized and sort of excreted out of your body through the kidneys. So that process is impaired, and there is a very rare 1 in a million or 1 in 10 million side effect called lactic acidosis, which can happen due to metformin in people with renal impairment due to other causes. So that's why people reduce or stop the metformin when they have kidney problems. But they put the wrong 2 and 2 together and say metformin causes kidney problems. So that's not correct. It's not scientifically correct.
Thank you, Dr. Manilka. Next, Dr. Chandimani, as you talk about these inhalers as preventers and relievers, some people, they tend to think that these inhalers, if they start taking inhalers, they can get addicted to it. And so there is a fear about it. What do you think about that?
Yes, Lushant, yes, that is a very valid point, because a lot of people stop taking inhalers because they think it's like a cigarette, because they take it from their mouth and they think that it is addictive. So I really want to stress and emphasize it is not addictive at all. Just that when they don't take, what they feel is they need to take it. So when they take it, they feel better. So they have to take it again. But if they regularly use a preventer inhaler, they won't need to take that blue inhaler or the reliever inhaler. So it is not at all addictive, and that's the way we treat asthma. So if there is a misconception like that, please take it out of your mind.
And one more question, as you said, sometimes exercises can exacerbate asthma attacks. So what are the exercises that you recommend? We recommend some of the exercises for patients with asthma. Are there any particular exercises that we recommend?
Exercise-induced asthma is a very specific condition where they actually only get symptoms when they exercise. So those patients, we tell them to take their reliever medication 10 minutes before they exercise, and they can do their sport. So that is one thing. With asthma per se, there is no particular exercise that we recommend as such, but swimming is supposed to help with asthma. So children with asthma, we tend to encourage them to swim if they're already doing it. Other thing is obesity. That means if you're really fat, that tends to make asthma worse. And also obesity itself can give rise to late onset asthma. So regular exercise to maintain your weight is very important in the management of asthma, like with the other two diseases that we talked about.
Thank you very much, Dr. Chandimani. As there are no more questions, and also we have taken more than 1.5 hours, I think it's time to conclude our session for today. And before concluding the session, I would like to wind up what we have talked. We talk about prevention of heart disease and overview of diabetes, and also we talk about asthma. So before we conclude, I would like to thank the Bar Association of Sri Lanka for the tremendous effort on organizing the webinar in collaboration with Ceylon College of Physicians. And in keeping with our this year theme of bridging gaps and crossing divides, this became the first effort to make ties with other professional bodies with Ceylon College of Physicians. And then I would like to extend my gratitude to Mr. Salia Piris, President Council, President, Bar Association of Sri Lanka, Mr. Rajiv Amarasuriya, Secretary, Bar Association of Sri Lanka, and Professor Arosha Disanayaka, President, Ceylon College of Physicians, for their guidance and support to make this webinar a success, to have this successful webinar. I would like to thank Dr. Neomali Amarasena, Senior Consultant Cardiologist, Dr. Manil Kasumanitilaka, Consultant Endocrinologist, National Hospital of Sri Lanka, Dr. Chandimani Undugodage, Consultant Respiratory Physician, Senior Lecturer, Faculty of Medicine, Sri Jayawardhanapura, for their excellent lectures on heart disease, diabetes, and asthma. Finally, without the participants, we could not have this webinar. So we had participants who are very active today. We had questions. Because of the limited time, we had to answer some of the questions personally. So thank you very much, all the participants, for their active participation to make this webinar a success. Thank you very much. Over to you to make final conclusions.
Thank you, Dr. Lushanti. On behalf of the Bar Association of Sri Lanka and the Seminars Committee, I would again like to thank Professor Arosha Disanayaka, President of the Ceylon College of Physicians, and our expert panelists today, Dr. Neomali Amarasena, Dr. Manil Kasumanitilaka, Dr. Chandimani Undugoda, and Dr. Lushanti Kannangara for this very informative, insightful, and valuable session. And I would also like to thank all of you who joined us through Zoom and YouTube, and for the questions that have made this webinar an interesting one. Thank you, everyone. Join us again next time on Sunday at 7 p.m. for another webinar in the series on a different topic. Stay safe and good night.